Welcome back to Studious. Today, we're laying the foundation for everything in dental anatomy, the structural map of the human oral cavity. Picture the upper or lower dental arch as a precisely engineered U-shaped structure. It isn't a random curve, it's a parabola with measurable architecture, a defined arch width, an arch depth, and curvature radii that change as you move from the front teeth to the back. This horseshoe shape isn't just for looks. Its geometry directly determines how forces are distributed during chewing, how teeth contact their neighbors, and how the entire bite comes together in occlusion. Every tooth sits at a specific coordinate along this arch, and that position dictates its shape, its root pattern, and its job. Before you can understand any single tooth, you need to understand the arch it lives in, because dental anatomy is fundamentally about structure in space. Over the next few minutes, we'll zoom from this big picture arch all the way down to individual cusps and grooves, then build back up to how the whole system functions together for chewing, speech, and facial form. Let's get into it.
Dental anatomy operates on two levels simultaneously, and you need to think in both. The first is surface anatomy, the microarchitecture of a single tooth's crown. Here you'll meet features like the cusp, which is a pointed elevation on the chewing surface, the groove, a linear depression separating those elevations, and ridges, such as the triangular ridge and oblique ridge, which are raised linear structures that guide how the upper and lower teeth interlock. These tiny landmarks aren't decorative. They're functional valleys and peaks that channel food and direct chewing forces. The second level is spatial arrangement, how a whole row of teeth sits together in the arch, upper against lower, in a precise interlocking relationship. A single tooth's surface detail only makes sense once you see how it meshes with its neighbors and its opposing partner. This dual lens, zooming into a cusp, then zooming out to the full arch, is exactly how dental anatomy exams test you. They'll ask you to identify a ridge on a diagram, then ask how that same ridge functions within the bigger occlusal puzzle. Master both scales together.
Before the teeth, let's map the room they live in, the oral cavity itself. 5 structures define this space. First, the lips, upper and lower, forming the anterior gateway where the mouth meets the outside world. Second, the cheeks, acting as the lateral walls that keep food within the chewing field. Third, the tongue, the central mobile muscle that manipulates food, aids swallowing, and is essential for speech articulation. Fourth, the floor of the mouth, the sublingual base beneath the tongue, clinically important because it's richly supplied with visible blood vessels, making it a key site for rapid drug absorption and for spotting certain pathologies early. And fifth, the gingiva, commonly called the gums, the soft tissue that hugs the base of every tooth and covers the underlying bone, forming a protective seal around each tooth's neck. Together, these 5 structures form the functional chamber where mastication, taste, and speech all happen. Examiners love testing this basic mapping because it's foundational. If you can't name the walls of the room, you can't understand what happens inside it. Keep these 5 locked in.
Now look upward to the roof of the mouth, the palate. Here's a high-yield concept. The palate isn't one uniform structure. It's split sagittally into 2 completely different zones. The anterior zone is the hard palate, and its defining feature is a solid, bony base. It's literally rigid bone covered by mucosa, and it extends backward all the way to the region of the wisdom teeth. The posterior zone is the soft palate, and it's the opposite in every way, composed purely of muscle and soft tissue, with absolutely no bone within it. This soft, mobile flap is what elevates during swallowing to seal off the nasal cavity, and it's what vibrates to produce certain speech sounds. Why does this distinction matter clinically? Because the hard palate provides a fixed, stable surface, useful for things like denture support and injections, while the soft palate's mobility makes it functionally critical for swallowing reflexes and snoring or sleep apnea pathology. One structure, 2 architectures, 2 completely different clinical roles. This bone versus muscle split is a classic anatomy exam trap, so don't mix them up.
Teeth don't float in soft tissue alone. They're anchored into bone, and that bone comes from two very different skeletal sources. The maxilla forms the upper arch, and it's a fixed bone, rigidly fused to the rest of the skull. It doesn't move on its own. It houses the maxillary teeth. The mandible, by contrast, forms the lower arch, and it's the only mobile bone of the facial skeleton, hinged at the temporomandibular joint, allowing it to depress, elevate, protrude, and retrude. It houses the mandibular teeth. This single distinction, fixed maxilla versus mobile mandible, is the entire mechanical basis of chewing. Every bite you take happens because the mandible swings up against a stationary maxilla, not the reverse. Clinically, this also explains why mandibular fractures, or TMJ disorders, create such dramatic functional problems, while maxillary involvement tends to affect static structure and aesthetics more than movement. When you're studying occlusion, jaw relationships, or even orthodontic treatment planning later, always come back to this core fact. One arch moves, one arch doesn't, and that asymmetry drives the entire mechanics of mastication.
To communicate about teeth precisely, dentistry uses a coordinate system built on two intersecting axes. The vertical axis is the midline, running straight down the center of the face, dividing the mouth into perfectly symmetrical left and right halves. The horizontal axis separates the upper arch, the maxilla, from the lower arch, the mandible. Where these two axes cross, they create four distinct zones: the upper right quadrant, upper left quadrant, lower right quadrant, and lower left quadrant. Here's the detail that trips up almost every new student. These directions are always assigned from the patient's perspective, not the observer's. So when you're standing in front of a patient looking into their mouth, the patient's right side is actually on your left as the viewer. This single rule prevents catastrophic clinical errors. Imagine treating the wrong side of someone's mouth because directions got flipped. Every chart, every radiograph, every treatment plan in dentistry is built on this quadrant system. So get comfortable thinking in the patient's frame of reference, not your own visual frame, starting right now.
Now that we have quadrants, we need a way to number individual teeth within each one, and that's where the midline indexing axis comes in. Starting at the midline, position 0, the numbering moves outwards symmetrically in both directions. Positions 1 and 2 are the incisors, sitting closest to the midline. Position 3 is the canine. Positions 4 and 5 are the premolars, and positions 6, 7, and 8 are the molars, with position 8, the wisdom tooth, marking the very end of the arch. This means every quadrant, whether upper right, upper left, lower right, or lower left, follows the exact same 1 through 8 sequence outward from the midline. So a 3 is always a canine, no matter which quadrant you're in, and an 8 is always a wisdom tooth. This elegant symmetry is what makes dental notation systems so efficient. Combine a quadrant identifier with a position number, and you've precisely located any tooth in the mouth using just 2 pieces of information. This index is the backbone of every numbering system you'll encounter later, so memorize this sequence cold.
Beyond simple position, the arch divides functionally into 2 zones with very different jobs. The anterior zone covers index positions 1 through 3, the incisors and canines, commonly called the front teeth. Their mechanical purpose is primary food interception. These are the teeth that make first contact with food, slicing and tearing it into manageable pieces as you bite down. The posterior zone covers index positions 4 through 8, the premolars and molars, the back teeth. Their mechanical purpose is breakdown and processing, grinding, crushing, and pulverizing food into a consistency ready for swallowing and digestion. This anterior versus posterior functional split explains a huge amount of tooth design that otherwise seems arbitrary. Front teeth are thin, chisel-shaped, and single-rooted because they're optimized for cutting. Back teeth are broad, multi-cusped, and multi-rooted because they're optimized for crushing forces. When an exam question asks why a molar has multiple roots while an incisor has one, the answer traces back to this exact functional zoning. Front teeth intercept, back teeth process. Keep that division in mind as we look at individual tooth types next.
Let's zoom in to the anterior zone's two tooth types. Incisors occupy index positions 1 and 2, with 4 per arch, 2 per quadrant. They further split into central incisors, sitting directly adjacent to the midline, and lateral incisors just beside them. Their primary function is precision cutting. Think of biting cleanly through an apple. Canines occupy index position 3, with 2 per arch, just 1 per quadrant. Structurally, the canine is described as the mechanical anchor of the arch, and that's not an exaggeration. Canines typically have the longest, most robust single root in the entire dentition, making them remarkably resistant to extraction and trauma. Their primary function is tearing and slicing, rather than clean cutting, which is why they have that distinctive pointed cusp rather than a flat incisal edge. Clinically, canines are often the last teeth standing in patients with severe periodontal disease, precisely because of that powerful root anchorage. When you're asked which tooth is most stable in the arch, the answer is almost always the canine. Remember that mechanical anchor description, because it's a recurring exam concept.
Now, the posterior zone. Premolars occupy index positions 4 and 5, with 4 per arch, 2 per quadrant, a first and second premolar. Their name is literally descriptive. Pre, meaning before, plus molar, because they sit just in front of the molars. Functionally, they're described as a transitional hybrid tool, sharing characteristics of both canines and molars. They have a more developed occlusal surface than canines, but aren't as broad as true molars. Molars occupy index positions 6, 7, and 8, with 6 per arch, 3 per quadrant, terminating at position 8, the wisdom tooth. Their primary function is heavy-duty grinding and structural support. Molars have the broadest crowns and the most extensive root systems of any tooth type, often with multiple divergent roots, which is exactly what you'd expect from teeth absorbing the highest chewing forces in the entire arch. This premolar to molar progression, increasing in size, cusp number, and root complexity as you move backward, mirrors the increasing mechanical demand placed on each position. Posterior teeth aren't just back teeth. They're a graded system built for heavier and heavier work.
Now let's connect tooth shape to function through the actual chewing sequence, mastication, which unfolds in 4 distinct mechanical steps. Step 1 is incising, the initial cutting and segmenting of food performed by the incisors as food first enters the mouth. Step 2 is tearing, gripping and tearing fibrous or elastic material, a job suited to the pointed, anchored canines. Step 3 is transitional processing, combining tearing with initial crushing. This is the premolar specialty, bridging the gap between cutting and full grinding. Step 4 is grinding, complete pulverization of food into a texture ready for digestion, accomplished by the broad, multi-cusped molars. Notice how perfectly this sequence maps onto the anatomical layout we just covered. Food literally moves backward through the mouth, encountering progressively more specialized tooth types at each stage, exactly in step with the front-to-back tooth progression along the arch. This isn't coincidence. It's evolutionary and functional design working in lockstep with structural position. Understanding mastication as this 4-step relay, rather than as one generic chewing action, is exactly the kind of integrative thinking dental anatomy exams are built to test.
Let's zoom all the way back out and see why all of this matters beyond just eating. The dental system as a whole serves 4 primary functions. Mastication is the mechanical breakdown of food for digestion, the function we just walked through step by step. Phonetics, or speech, relies on teeth as essential structural points for precise vocal articulation. Try pronouncing certain consonant sounds without your front teeth, and you'll immediately understand this role. Aesthetics, or appearance, matters because dental alignment directly dictates facial structure and visual presentation. Missing or malpositioned teeth can noticeably change someone's facial profile. And maxillofacial growth ties it all together. Tooth positioning actively guides the biological development of the jawbones themselves, especially during childhood and adolescence, which is exactly why early orthodontic intervention can influence overall jaw development, not just tooth alignment. These 4 functions, Mastication, phonetics, aesthetics, and maxillofacial growth are why dental anatomy sits at the intersection of medicine, surgery, and even psychology. It's never just about teeth. It's about the entire craniofacial system working as one. That wraps up our foundational tour of dental anatomy.